Without much further ado, and as Dr. Eli Odongo has alluded to, it is important for us to affect the policy space to improve maternal and neonatal care. We want to welcome Dr. Elizabeth Waithera Gitau to give us the chief guest remarks. Welcome, Gitau.
It's indeed a pleasure to be able to be with you here today. I am with utmost humility to OBGYNs for the support personally and also in the health system. I am a mother of 3, so I have benefited a lot from the services of obstetricians. Additionally, I also sit in the medical council, as has been said, and I sit in the disciplinary hearings, and a significant portion of our cases are usually gynae cases, obstetrics mostly, a few gynae, but mostly obstetrics. And partly it's because of the risky nature of the career, but also partly part of the presentation that we shall do here in terms of what is the role of the gynae in health system, because a lot of the issues that we find in a disciplinary case is not skill issue, it's mostly a system issue. So what can the obstetrician do to ensure that this system is good, so that we don't end up in situations that we end up mothers dying because either the system was not working properly and we were not taking leadership at that. So thank you very much. So as has been mentioned, the additional name I have there is minor. So I was told, that's my little Toto. So I was told before you make any presentation, so that it is relatable to people, so that you must bring photos of yourselves or your family, so that's my last born, little girl, delivered by one of you. I think Dr. Kigondu took that photo, yeah? Yeah? Yes. So he was not the obstetrician, he was just a photographer. All right, so I have an 11-year-old daughter, and she's in the stage where she was always telling me jokes. So I asked ChatGPT to help me to see what are some of the obstetrician jokes that we can come up with. So one of them is, why are OBGYN in Nairobi always tired? Because they are on call more times than Safaricom customer care agents. So why don't Kenyan obstetrician gamble? Because they take chances every day. It is either you go to the ward, there's no oxytocin. Referrals, umelala, unasikia kuna referral. Power outages, you're in the middle of a C-section and boom. So you're already taking chances. And the last one there, I'll not read the third one. The last one there is, why did the OBGYN lecturer take 3 hours in a county CME? And it is for the reason, because everyone kept interrupting and asking, na kwa setting, unawezaje manage bila CTG? Yeah. Okay, so we are used to working in resource-limited situations. So those are some of the things. So I was happy to listen to Dr. Eli Odongo, because a lot of the things that he spoke about, you see in my presentation, because essentially that is our role beyond just the clinical setting, that is our role. This number here should worry us significantly in terms of Kenya has had the MR of 355, and this is data from KDHS. There's significant evidence from the last census that this number could have been higher if we used the 2019 data. So there's a slight decline from 362 in 2014, but it's been stagnant. I think we can do better. I tried to look at our neighbors. They are doing, in terms of the economy, they're doing worse than us. We are doing better in the economy. However, our numbers are higher than theirs. Yes, that's why they're deporting us, because we cannot even take care of our mothers. So as you see, Tanzania 238, and it's actually going down. When you look at the data as the years go by, there's something right that they are doing that in our setup, we possibly need to think more what we can do better. Rwanda, of course, two or three, significant progress there. Globally, we are at 223, declining, but has stalled, especially in low and middle income countries like ours. Our target, do you know our MMR target as part of the SDG? Do you know what we are looking forward to? 70. So if you're looking for 70 and you're at 355, that is almost more than 5 times, yeah? So it means that we have to reduce our maternal mortality rate by more than 5 times for us to be able to reach the target of no mother dies while giving birth. So these are some of the things that you do on a day-to-day basis, so I'll not take time in that in terms of your participation in the entire spectrum of life, whether it is in family planning, contraception, whether it is taking care of mothers when they are pregnant, whether it is in dealing with reproductive health disorders, whether it is in prevention and treatment of various cancers. You do adolescent and sexual health, safe abortion, and postnatal care where it's legal. So this is what you do on a day-to-day basis as part of supporting the health system. So when people talk about health system strengthening, you are right at the center of the health system. So those are when people talk about health system strengthening, there's nothing big they talk about. They just talk about these 6 things that you already know. And I like this photo. There's usually that building blocks that are separate, but I like this circle because essentially it puts leadership and governance at the center, because that is what our country lacks. Leadership and governance, whether it is us as obstetricians or our politicians. How are we leading in our counties? How are we leading in our hospitals to ensure that mothers are not dying? So we'll look at all the building blocks and we'll end up at leadership and governance and see what can I as an obstetrician do to make sure that I'm strengthening the health system in my own individual way. So we have service delivery, human resources, medicines and technology, financing, and information. And allow me, I'll be repeating a lot of what Dr. Eli mentioned during his presentation. So what is health system strengthening? Basically, health system strengthening is a process of improving the health system performance and using the 6 building blocks, and so that it can deliver high quality, equitable, accessible healthcare services. So every activity using the 6 WHO building blocks that leads to people getting care which is accessible and it's equitable and of high quality. So for obstetricians, our participation in health systems is going beyond our clinical work. It's not just delivering a baby. It's not just doing a hysterectomy. It involves engaging in the design, improvement, and leadership of the broader system that support maternal, reproductive, and newborn health. And a lot of work that has been done by COGS as an association needs to expand so that you can have more the work that the national office is doing, the central branch is also doing within the counties to ensure that all efforts are put together. Okay, so in terms of service delivery, and this is what we are more familiar with because that is what we are trained to do. So in terms of providing skilled care, that is your duty in terms of what you're trained to do, and majority of us do that very well. But when it comes to leading clinical governance, I go to number 4, leading clinical governance, audits, and mentorship in the facilities. That is where we possibly do not see it as our core function as clinicians, but essentially it is one of the things that can make your clinical practice way better within the facilities that we work with, whether you work in public or private. Leading initiatives for EMONC and respectful maternity care. So it is your duty in terms of the building block service delivery, it is your duty as the obstetrician wherever you work that you're leading the initiative to ensure that EMONC is done and there's respectful maternity care. There's no, if you have done an EMONC training and you do not train your midwives and your AMOs, the mothers will still die because you cannot be there every day. So anytime you attend a training, you do not need to get paid by the county again for you to train people. You train on job as you go, and that is your contribution to health system strengthening. Health workforce development is the next one. So in terms of health workforce development, 4 things that you can do to strengthen the health system: train and mentor. And today I've seen you're also doing adopt a pre-intern, so that's part of mentorship. Train and mentor GPs, midwives, clinical officers, medical students within the spheres of influence that you have. Significantly advocate for deployment and retention of skilled birth attendants at all levels. You have no, as an obstetrician, you're the leader. So you must take your space and ensure that in terms of advocacy, you're the person writing more letters to the governor, more letters to your CEO to ensure that you actually have skilled birth attendants at all levels. Because any mishap across the line of work, by the time the mother enters the health system, will eventually end up at your desk. Again, strengthen capacity for interdisciplinary collaboration. So what is the role? Like, how do we as obstetrician define the role of what a CORH can do? Because if we do not pronounce ourselves as obstetrician to the extent of which this particular clinician or a nurse can go to, then it becomes to anybody's interpretation, including the politician's interpretation of what they can do. Promote CMEs and subspecialization. I've seen a lot of that in terms of CMEs where obstetrician within COGS and otherwise promote CMEs. Subspecialization. As we advance in medicine, there'll be more collegiate training. And the Medical Council is advocating to have more collegiate training. So within COGS, I do believe we shall have more collegiate training of obstetrician in various subspecialties so that we can be able to have more gynecologists across the country, which are not just trained at UON or MOI. They should be trained on a continuous basis, even here in Meru, because we already have faculty that are going on. On HMIS, or Health Information System. So here is one, to strengthen the use of MPDSR, and it's quite encouraging that I've been seeing gynaes take leadership in terms of ensuring MPDSRs are done within the facilities, within the counties. Ideally, every facility should have an MPDSR committee led by the obstetrician, so that you're not waiting for the county to have a death for you to have MPDSR. MPDSR is surveillance and response. So surveillance also means also the near misses. Because the near misses, you're the one who knew a near miss. If a mother walks out alive, but you know that mother could have died, it is important that as a facility you do your MPDSR under your leadership so that you make sure the next time you don't have a mother dying because of the same reason that one may be survived by God's grace. Advocate for deployment and retention of skilled birth attendants. Again, health workforce. So advocacy comes in at every of the health system building blocks. Collaborate in research and surveillance. This is one of the weaknesses that we have as low and middle income countries. We have no data. We have no data to inform decision making. We are dependent on writing grants. We are dependent on USAID to come and write grants and conduct our research. Yet we see these patients every day. Your MO sees these patients every day. So you can actually develop an easy operational research. It does not need to be grant related. It does not need to be funded. It just needs for us to be able to say, for every patient that we see, what is our outcomes? How are we measuring our outcomes? What are some of the interventions that we're able to put in place? So if every facility was to publish papers every year, can you imagine the amount of data would have? A lot of us practice in darkness because we have no data. By the time you're going to COGS, you're presenting data from, your literature review is full of data from other countries. Instead of having data from Meru and we should be asking ourselves, where are mothers in Meru possibly getting preeclampsia than other regions? So that data should be available, and it is our role as obstetricians, as head of the reproductive maternal health, to be able to support the writing of this research. Essential medicines and technology. One, in terms of do we ask ourselves whether we have enough commodities within our facilities? If you're running a private hospitals, most of the time you'll actually go every day to check whether you have commodities. But somehow within the public system, we assume it's not our role. It is the pharmacist's role for them to have oxytocin. So if we do not take leadership at that level to make sure that we are advocating for, did I move? No. Uh-oh. There we go. Scourges. Okay. All right. So in terms of availability and rational use of essential drugs like, let's say, oxytocin, blood products, ultrasound operating theaters, part of you having done information, improving your data use, and now which you can use in advocacy. Because sometimes we say there are no oxytocin, then tomorrow they are brought, then that's the end of it. But if you're able as an obstetrician to chart that in this facility, we've had oxytocin for only 10 days out of the 30. You see, that becomes a better advocacy ground than just saying, huku hatunanga oxytocin. But you're able to actually say, from the time I operated, I only had oxytocin in 10 of those days. I'm using that as an example. In terms of blood, how often do you get blood? What is the time limit? And that you can only do if you have enough data for you to be able to track. Again, we listened to Dr. Eli talk about emotive. So when it comes like for the PPH drips, do any of our facilities have any of our facility procured the PPH drip? The calibrated drips. Any of our facilities with the drips? So you see, beyond the study, you're the one who knows about this drip. The rest of us, we possibly do not know that drips exist. But you must advocate that they be added to the procurement list because it is part of your work. And that is the only way they can get utilized. Because even if I know there's a PPH drip, but it is not procured, there's no learning that has occurred because I can still not use it. So beyond now, once Eli and team and Dr. Amai have presented that there's this drip, your next question will be asking, who supplies these things? Who is a local supplier? Because I'm told there's a local manufacturer doing these PPH drips. Yes, there is. So, yes, there is a local man. I supported part of my work. I used to work for Population Services Kenya, and part of the USAID work we were doing, we were supporting adoption of the e-motive. Unfortunately, our grant came to a stop, but adoption of e-motive as part of private sector engagement, where we ensure that we link the supplier to the hospitals. So that is why I know that this thing is available locally, but the only way it can get adopted is when the obstetrician writes and says, I want this PPH drip in my ward. Next, supply chain monitoring and procurement processes. Again, be aware. It should be part of your reports. This is not just for the med soup. Because the day you come there and you're not able to operate, it is you who will suffer the consequences. Or the time you have to refer a mother because there's no oxygen, because you have never bothered to check the levels of oxygen, or you've never bothered to check how they procure oxygen. For you to even know, you should not be bringing mothers here because this hospital does not have oxygen. Mothers learn, and even you're as shocked as a patient. Advising on technology adoption. Again, we've attended so many training for POCAS. I don't know whether we have written to our MedSoup or we have written to our counties to procure POCAS, or we have written it in our needs analysis for technology adoption, because that is the only way it can get to strengthen our health system using essential medicines and technologies. Finally, the second last is in terms of health financing. So for health financing is participating, and I know COGS has participated during the UHC discussions and even SHA. So is in terms of giving feedback of what is working, what is not working. For the many, many years that we have worked under Linda Mama, Linda Mama provided access, but also Linda Mama brought a bit of trouble in terms of the amount that was being reimbursed to facilities. So it is, when you look at it on the bigger picture, you've provided access, but you're not sure the quality of that access that you're giving. And the only way for people to know is when obstetricians talk and say, yes, we love Linda Mama, the mothers are able to come to the facility, but 17,000 cannot section a mother. And that can only come from the data that you have collected in terms of what do you really need to do a cesarean section. Because sometimes I work with private sector a lot. A lot of those discussions, when they come from the private sector, they look like you're just looking for money. But if they come from the clinician, they come from the county hospitals and saying, for me to do a cesarean section, I need 20 drips, I need this amount of hours, I need this. You can be able to say, for us to effectively do a cesarean section, it probably would, at cost level, cost 30,000. So giving a facility 17,000 will kill another mother. It may save this one today, but if supplies are not coming on time because you're reimbursing very little amount, I will kill the next mother. So supporting integration of UHC, providing data, we go back to data. And I think that will be my only message for today, that we need to participate more in developing, interacting with the data within KDHS, developing small studies within our various facilities that provide advocacy material for COGS to be able to go and say, in this region, these are our issues with numbers. Because if you don't go with numbers, it looks like just complaints. So advocating for increased investment, we talked about, and again, advocating for equity in access. So COGS should be the one in terms of health financing saying which regions have more gynaes, which one have less, where should you take more. So the last one is on leadership and governance. And as you remember, this is the core, and this is where we are being called to participate. So one, participate in the national technical working groups. That one COGS does very well. But at regional levels, are we doing it within our counties so that we augment the work that is being done at national level? Advice on policy development, clinical guidelines and protocols. Do we know what is in our counties? Do we know what is in our facility so that you can provide guidance and leadership? Of course, participating in various association, COGS, or which is the other one? The progressive ones that advocate for women's health and professional standards, and also supporting regulatory oversight through KMPDC and in collaboration with MOH. Some of the I don't know, I hope in our country we'll get to a point where we adopt self-regulation, and also we are more open to formal reporting. Yeah, we hear a lot of stories outside, but when you tell people to report to KMPDC, nothing. Things are not done. So I think in terms of working with the regulator for us to be able to ensure that we are offering quality care. So finally, what is our call to action? What do we call the obstetrician and gynecologist to do? The gynecologist is the frontline leader in reproductive, maternal, and newborn health. And you must take an active role in shaping and strengthening the Kenyan health system. I know you work with a lot of midwives, you work with clinical officers, you work with medical officers, but you're the leader. If you do not lead, they will come and lead. And sometimes they'll give advice that is not at the highest level. That you can only lead as per your level of training, your level of exposure. So if you let other people lead and you have more exposure, that is why you'll always complain that things are not working. So beyond the clinical care, I know it's easier to just come and see patients and go home. Beyond the clinical care, your voice, your leadership, your expertise is very, very important. So lead beyond the ward. Lead beyond the ward, champion quality and equity, strengthen the health workforce through mentorship. A lot of the younger colleagues, I know in our setup, possibly mentorship has not been very structured, but we have an opportunity to structure it more as we go along. Advanced data-driven practice. If you've never seen any data for KDHS in your facility, just go and ask for it. Because this data is available, it is free to access. you can actually go to facility level. You do not need KDHS for the country. You just ask for the HRIO to give you data for your unit. You'll be able to see all those babies you deliver that are preterm. You'll be able to see all those mothers who died, the ones who had various complications, and it enables you to even track and say, maybe in October, more mothers have preeclampsia. What could be the reason? Such things. And also be the voice of change. So finally, a strong health system is not built by policy alone. We can have the best policy in the world, but it is built by professionals who lead with purpose, they act with courage, and advocate with evidence. I repeat again, they act with courage and advocate with evidence. If we don't have evidence, our advocacy ends at a certain point. It just becomes noise, empty debe. But if we come with data and say, me, I usually deliver 1,000 mothers and 10 are dying, and the reason they are dying is because the blood bank is in Meru and I live in Embu. Why don't we create one here? Such things. You're not only healers as obstetricians, you're architects of a better, a safer, and a more equitable healthcare system for all Kenyan women. Thank you very much.
Apewe makofi mwingine tena. As my intern, Dr. Waithera did 150 cesarean sections in Murang'a County in the year 2013. She was then proceeded and became the CEO of KMA, sasa KMPDC, in the disciplinary committee. Disciplining akina Nyongesa. That's how fast. And then maybe when we look at the adopter pre-intern program, these are some of the things you see. You want to build capacity for your young ones so that they're able to even implement policy changes at a country level. Alikuwa prayer breakfast jana, just to say that me, president wa KMS, kupata invite, but how she got as KMPDC disciplinary committee. Aya.